Good afternoon, ladies.
Good afternoon, sister.
Good afternoon, sir.
Good afternoon, Doc.
You're all welcome.
Thank you.
Thank you, Prof.
When is the midsem coming up? You have an idea?
No, please.
Okay. Okay. Last week we started talking about hypertensive disorders, which I have already given you the notes. We did say that hypertensive disorders during pregnancy are called maternal or hypertensive disorders, and they are a kind of group. They are group diseases. You have to do with preeclampsia, eclampsia, gestational hypertension, and then chronic hypertension. When we talk about chronic hypertension in this area, we are talking about a situation where a woman is already hypertensive, a known hypertensive woman who now gets pregnant. I told you that some people use hypertension in pregnancy interchangeably. Actually, hypertension in pregnancy is, when you talk about hypertension generally, so the first thing we have under there is the gestational hypertension. The gestational hypertension, I remember I made a statement last week. I said, just like the gestational diabetes, this woman is a non-hypertensive pregnant woman. Her baseline shows that she's not hypertensive, only for her to come up with hypertension because of pregnancy. And I did say that the actual cause is not known, but it wraps around suspicions, wrap around the placenta, the trophoblast. And that is why I said last week that when a woman, a mother, has gestational hypertension, which comes with preeclampsia, eclampsia, and all things, the moment the placenta is out, that problem is solved. Take out the placenta, and she is all right, except and unless a very serious damage had occurred already. So the classification, you have gestational hypertension, you have preeclampsia, eclampsia, chronic hypertension, and preeclampsia or eclampsia superimposed on chronic hypertension. Preeclampsia, pregnancy-induced hypertension. Again, a lot of people use preeclampsia and pregnancy-induced hypertension interchangeably. That is because most women who have pregnancy-induced hypertension develop preeclampsia. So the definition is a multi-system disorder of unknown origin characterized by development of hypertension to the extent of 140-90 millimeters of mercury or more, with proteinuria after 20 weeks in a previously in a previously normotensive woman. Previously, she didn't have any problem. She came into pregnancy and developed that problem. So we went as far as talking about the classification. Can somebody please, in fact, I don't know, maybe because I came in a few minutes late, I didn't bother to give time for the latecomers, but we are okay. So we said last week that preeclampsia is classified into different groups. You have preeclampsia itself is classified into the primary preeclampsia or eclampsia, and then the secondary. The primary preeclampsia, you have it that about 70% have primary preeclampsia. Then about 30% have preeclampsia superimposed on chronic hypertension. That is preeclampsia on women that have chronic hypertension. And this one is about 20%. And then the other one is 5%. Preeclampsia, eclampsia. What is under it? I have this board covering that doesn't want to go down. Please read the last one there. Superimposed on chronic renal disease. Thank you. So we talked about this last week. And then again, classification based on severity. Number one is preeclampsia or mild preeclampsia. Then you have the moderate and the severe preeclampsia. So for the mild preeclampsia, the systolic pressure is 140, between 140 and 160. While the diastolic pressure is between 90 to 100 millimeters of mercury. And then you have up to 2 pluses. Ms. Hiratu, can you please mute yourself? There's a noise in your background that is distracting the class. And then severe preeclampsia, the systolic is above 160. The diastolic is over 110 millimeters of mercury. And then it has about 3 pluses of protein in urea or more, accompanied by epigastric pain. That is the severe. Then the risk factors. When we talk about primary gravida, that is the young ones, pregnancy-induced hypertension is common among them. Nobody seems to know why. It's very common among the very young ones. Those ones 17, 18, 16. You could also have that in the elderly primates. Family history of hypertension or preeclampsia. Placental abnormalities. You have the hyperplacentosis. Hyperplacentosis is found in twins, in diabetes, and in molar pregnancies. You have poor placentation, placental ischemia, molar pregnancy, genetic disorders. immunological phenomenon. You have like the pre-existing vascular disease, new paternity. I tried to explain. Then thrombophilias. New paternity, usually a woman may have had a child or two, and she didn't have that problem. But she happens maybe to have a broken relationship, and then she comes in pregnant from another person, a different person from the former one she's been dating or she was married to. And there is incompatibility. Etiology of preeclampsia. I told us that it is surrounded around the trophoblastic invasion, that is around the placenta. So number one, placental implantation with abnormal trophoblastic invasion of uterine vessels. When the trophoblastic invasion is abnormal, then you have the next point, immunological maladaptive tolerance between maternal, paternal placenta. And fetal tissues. Where there is maladaptation, where there is incompatibility between the mother and the father of the fetus, that incompatibility is centered in the placental tissues. And when that happens, the fetal tissues suffer because they receive the end products. And that's where the reaction starts before enough affects the mother. Then you have maternal maladaptation to cardiovascular or inflammatory changes, where the pregnancy ordinarily is supposed to be a normal pregnancy. If there is inflammatory condition, if she's infected with any infection, where you have cardiovascular issues. So normal pregnancy can change to have problems. And then you have genetic factors. We handled this. Who remembers exactly where we stopped? Am I alone in class?
No, sister, you are not alone.
Okay, Ernestina, help us read.
Please, clinical features of preeclampsia. Signs: abnormal weight gain that is greater than, please, I can see, that is greater than 5 IB per month or 1 IB per week in later month. Rise in blood pressure. Edema, that's the ankles, then spread all over the body. Pulmonary edema. Abdominal examination. Chronic placental insufficiency. That is scanty liquor or intrauterine growth retardation. Please, sister, should I continue?
What is this LB? 5 LB, 1 LB.
It's the 5 pounds.
What?
5 pounds.
Continue, Ernestina.
Okay, sister. Mild symptoms. Slight swelling over the ankles, which persists on rising from the bed in the morning, or tightness of the ring on the finger, is the early manifestation of preeclampsia edema. Gradually, the swelling may extend to the face, abdominal wall, vulva, and even the whole body.
If nothing is done. Hello?
Hi.
If nothing is done.
Alarming symptoms. 1. Headache, occipital or frontal region. Disturbed sleep. Diminished urinary output. That is, urinary output of less than 400 mL in 24 hours. Epigastric pain. Eye symptoms, that is blurring, dimness, and vision or complete blindness.
We look at these signs and we think, oh, we are just learning. It may happen. But of the truth, these things happen. So let's stop here and let's find out who has nursed a patient with any of these signs. Particularly blurred vision, dimness of vision, or complete blindness. Very common. Headache. Very common. Has anybody nursed them? Epigastric pain. Hello.
Hi.
Has anybody nursed them? Ernestina, continue, please.
Okay, sister. Investigations. 1. Urine proteinuria. 2. Ophthalmoscopy. Ophthalmoscopic examination, that is retinal edema, constriction of arterioles. Blood values, that is the BUN, serum creatinine, thrombocytopenia, coagulation profile, liver function test, antenatal fetal monitoring. That is the use either the ultrasound scan, fetal kick count, cardiotocography, umbilical artery flow, velocimetry, biphasic profile.
These are investigations that are prescribed and carried out in the laboratory.
Maternal patients, immediate, that's the antenatal. Eclampsia, 2%. Accidental hemorrhage, oliguria and anuria, dimness of vision and even blindness, preterm labor, HELP syndrome.
All these are immediate signs.
During labor,
Continue.
we have eclampsia, postpartum hemorrhage. During prepurium, eclampsia, usually within 48 hours. Shock, sepsis.
You know, eclampsia during puerperium is very severe.
Yes.
It's also very severe because, like we say, normally after the placenta is removed, there should be relief. But this one is occurring even when the placenta is not in situ. It can be quite severe.
So please, sister, I have a question. I want to know, the placenta is out, but still the person will have that eclampsia. So I want to know what, I know that the BP have not subsided yet, but I don't know why the placenta is out. Then still eclampsia will set in.
Nobody knows why, because we know that with the placenta there, those things can happen. But the simple explanation could be that whatever foreign protein that was introduced by the abnormal placenta must have gotten into the system. That's the only explanation.
Okay, thank you. Fetal complications.
Please, I have a question. So, like in that case, do we give masks off or what do we give to?
You still manage the way you're managing. You still manage it the normal way. Because these organisms are in the bloodstream. Are we all right?
Thank you, sister.
You're welcome.
Fetal complications. Intrauterine death. Intrauterine growth restriction. Asphyxia. Prematurity.
These are the complications. The baby may die. The growth may be interfered with. That baby may be asphyxiated or even born before time. Then you have remote complications to the mother now. Go ahead.
We have residual hypertension, recurrent preeclampsia, chronic renal disease, risk of placental abruption.
Risk of placental abruption when? Hello?
Hi.
Yes, sister.
When? Residual hypertension when?
Yes, please. Risk of placenta abruption during pregnancy.
Which pregnancy?
Sister, please, maybe during late pregnancy, that is after 24 weeks of gestation going.
Subsequent pregnancy. Remote complications. When you talk about residual hypertension, it means that the hypertension could be sustained. When something is residual, you have finished and you thought you are done with, but that thing is still there. Recurrent preeclampsia, next pregnancy. Renal, chronic renal disease, continuous. Risk of placental abruption. It depends on when this condition started. If it is in early pregnancy, when in the late pregnancy, that could happen. So these are remote contractions and complications that we must look out for. Continue.
Preventive measures. Regular antenatal checkup. Antithrombotic agent, low dose aspirin, 60 milligram daily. Calcium supplementation, 2 grams per day to reduce risk of preeclampsia. Antioxidant, vitamin E and C. Nutritional supplementation with magnesium, zinc, fish oil, high protein and low salt diet.
So, I want to ask, what do you use on the wards to prevent these conditions? Do we use aspirin as routine and calcium? Do we give them to women routinely?
Yes, please.
You give calcium routinely to
Yes.
every pregnant woman
Antinatally.
in the antenatal?
Yes, please.
And you give aspirin routinely to every woman?
No, the aspirin I've been given to the chronic HPT or the pregnancy-induced hypertension people. But for every woman we give.
Okay, what about vitamin E and C?
I know of vitamin C being given routinely, but for vitamin E, no.
Oh, okay. And then the nutritional supplement, this one we normally advise them on what to take.
Yes, please.
Yes, sister.
Continue.
Yes, sister. Management of preeclampsia. Objectives. 1, to stabilize hypertension and to prevent its progression to severe preeclampsia. 2, to prevent the complications. 3, to prevent eclampsia. 4, delivery of a healthy baby in optimal time. 5, restoration of the health of the mother in puerperium.
So that is your objective. That's why you're doing that. You want to stabilize the condition because you know that if the condition is not stabilized, it will progress to preeclampsia, to severe preeclampsia. And when it moves to severe preeclampsia, of course, eclampsia is imminent.
Yes.
You want to have a healthy baby at the right time. And even though it is not written there, a healthy baby and a healthy mother. And as much as possible to make sure that during puerperium, the mother is healthy enough to take care of the baby.
Treatment modalities rest. Treatment modalities, that is rest, in left lateral position as much as possible. It lessens the effect of vena-caval compression, increases the renal blood flow diuresis. Increases the uterine blood flow, that is, improves the placental perfusion, then reduces the blood pressure.
So that's why you must ensure that that patient is resting. And not just resting. The position of the rest is important.
Diet should contain adequate amount of daily protein, about 100 gram. Total calorie approximate 1,600 cal per day. Usual salt intake is permitted. Fluid needs not to be restricted.
Yes. The diet should be mindful of what she takes. She should not just eat for eating's sake, but it must be adequate.
Sedatives. To cut down emotional factor, mild sedative may be given orally, that's the phenobarbital 60 mg or diazepam 5 mg at bedtime is given.
Yes. You want to make sure that she has to sleep when she should sleep. She will not lie down there and be worried.
Diuretics should not be used injudiciously as they can harm to the baby. They can harm to the baby. They can harm the
They can
baby.
cause harm.
They
They
can
can cause
cause
harm to the
harm
baby.
to the baby
So
by
what cause is not there here?
Can cause harm to the baby by diminishing placental perfusion and by electrolyte imbalance. Indications for diuretics use are cardiac failure, pulmonary edema, along with selective antihypertensive drug therapy, then massive edema. Oral antihypertensive drugs, methyl-dopa 250 to 500, TID or QID, central and peripheral anti-adrenergic action. Labetalol, that is 250 milligram TID or QID, adrenoceptor antagonist. Nifedipine, 10 to 20 milligram BD, that's calcium channel blockers. Hydralazine, 10 to 25 milligram BD, that is vascular smooth muscle relaxant.
Do you understand this? That is, they tell you the drug and they tell you how it works. Methyl-dopa will work on the central and peripheral anti-adrenergic action. So for each of the drugs, they're telling you its action, the scientific principle of using it.
Progress charts. Blood pressure, that is Q6H, state of edema and daily weight, fluid intake and output, urine examination for protein per 24 hours, blood examination, that is hematocrit platelet count, hematocrit platelet count, uric acid, creatinine, LFT once a week.
Why you say Q6H, what do you mean? Q6H. Hello.
Hi.
Hi.
When you say Q6H, what do you mean? It simply means quarter hourly or 6 hourly.
Okay.
Ideally, it should be QH or 6H. So it's actually talking the same thing, quarter hourly or 6 hourly.
Methods of termination. Induction of flavor. That is aggravation of the pre-eclampsia features in spite of medical treatment and or appearance of newer symptoms. Hypertension persists in spite of medical treatment with pregnancy reaching 37 weeks or more. Acute fulminating pre-eclampsia irrespective of the period of gestation. Then post-term pregnancy.
What do we mean by acute fulminating preeclampsia? Yes.
Well, please, with my understanding, I think it's like when maybe the decrease and things are deranged, or when you do the lab, the LFT and things are deranged. So you are perceiving that definitely eclampsia can happen. So no matter the gestation, it will terminate the pregnancy.
You said the blood pressure does what?
I'm like, when you do the BE and cryostoming, the LFTs and things, and you see that maybe they are deranged. They are deranged.
Beatrice will not let us hear you. Beatrice will not let us hear you. Who is the co-host? I'm trying to mute her. I'm not able. Okay, she has muted herself now. Can somebody check for the fulminating preeclampsia or eclampsia?
Hello, Prof.
Yes, please.
Good afternoon.
Good afternoon.
Please, it says that it represents severe preeclampsia with explosive, rapid onset with multi-organ dysfunction occurring over hours, not days. So it's so sudden.
Thank you.
Welcome.
Thank you very much. When you talk about fulminating preeclampsia or fulminating eclampsia, is a situation where the signs come very rapid. In few hours, a lot of harm is done. Somebody is sitting down, nothing is wrong with the person. The person must have come to the clinic and gone back in 2 or 3 days, or even yesterday. And she gets up, the first thing she will tell you is headache. As you're talking about the headache, the next thing she will tell you is that she has blood vision. Her vision is not clear. You look at her, there's edema, everything very rapidly. That's what we mean by fulminating. Fulminating eclampsia. fulminating preeclampsia. Beatrice, why have you unmuted yourself now?
Gloves were how? Winning gloves from disposable gloves. Ebi ni ho. Okay, oko gan ni ho ebi wo ho. Madam Charlotte. Oh my. Ne Johnson no. Pako lab na.
Beatrice, please mute yourself.
Okay. What we just finished is induction. Yeah.
Please, I have a question. So in this case, the fulminating eclampsia, is it what they said, like everything just happened all of a sudden?
Yes.
There are no any warning sign before the person is
No
fitting
warning
on.
signs.
No BP previously, but she's fitting on you.
So you will hear her, but one of the first things is usually headache. She will tell you, I have headache. Before you know it, everything, all the signs you're thinking of manifest.
Oh, okay. Thank you.
You're welcome. Ernestina?
The methods of termination, that's cesarean section. Urgent termination is indicated and service is unfavorable. Severe preeclampsia, associated complicating factors such as early primary gravidity, contracted pelvis, malpresentation, etc.
So when it happens like that, you severe preeclampsia, there are complications. And when you look at her, she's an elderly primate. Please open her up and give her her baby. There's contracted pelvis. The presentation is mild. Open that woman up and give her her baby.
Management during labor. Patient should be on bed. Liberal sedatives, antihypertensive drugs. Blood pressure and urine output is monitored. Care monitor of fetal well-being. Labor, that is artificial rupture of membranes and deliver by forceps or ventus. IV ergometrin is contraindicated. IM oxytocin is given. Sedation immediately. IM morphine 15 milligram to prevent postnatal eclampsia.
Why is ergometrin contraindicated intramuscular?
Hello, Prof.
Yeah.
It increases the BP.
We are talking about blood pressure. And ergometrin has a tendency of raising the blood pressure. So you have to keep it aside and rather use oxytocin.
Close monitoring. Management of purpura. Close monitoring for at least 48 hours. Tab phenobarbital 60 mg is repeated for effective sedation. Antihypertensive drugs is given until diastolic pressure is below 100 millimeters of mercury. Patient is hospitalized until BP brought down to safe level and proteinuria disappears.
That's it. Because management in the hospital is not the same as management at home. So you must manage that condition until it stabilizes. You continue with antihypertensive drugs until she lands safely.
Definition of eclampsia. Pre-eclampsia, when complicated with generalized tonic-clonic seizures and or coma, is called eclampsia.
Yes, when preeclampsia is complicated with fits.
Pathophysiology of eclampsia. Since eclampsia is a severe form of pre-eclampsia, the histophysiological biochemical changes are similar, although intensified than those of pre-eclampsia as already described.
ICT, please make somebody a co-host. So we are talking about the pathophysiology of eclampsia. And we all know that eclampsia develops when preeclampsia is not effectively controlled. And so what do? We have to make sure preeclampsia is handled effectively.
Stages of eclamptic convulsions. The eclamptic fits are epileptic form and consist of 4 stages that are 1. Premonitory stage. The patient becomes unconscious. There is twitching of muscles of face, tongue, and limbs. Eyeballs are turned to one side and becomes fixed. This stage lasts for about 30 seconds.
Yes, the premonitory.
2. The tonic stage. The whole body goes into a spasm called trunk opisthotonus. Limbs are flexed and hands clenched. Respiration ceases and tongue protrudes between the teeth. Cyanosis appears. Eyeballs becomes fixed. This stage lasts for about 30 seconds.
So you see the tonic phase. You see the whole body will go into spasm, the opisthotonus. Like you see in children. And here is a pregnant woman. Respiration ceases. The tongue protrudes between teeth, and the teeth will be biting the tongue. For the cyanosis, you can't really appreciate it with the blacks. If it's the white, yes. The eyeballs become fixed. That is the tonic stage.
3. Clonic stage. All the voluntary muscles undergo alternate contraction and relaxation. The twitching starts in face, then involve one side of the extreme, and ultimately the whole body is involved in the biting of tongue, taste, breathing, strenuous and blood, thin secretions filled. Cyanosis gradually disappears. This class from 1 to
Class rep, have you been made the co-host?
Yes, sister.
Yes or no?
Yes, please.
Please, if you are a co-host, mute that Annabelle or put her completely in the waiting room.
She is there now.
Thank you. So the fun is that all the stages you have in convulsion are here.
4. Stage of coma. Following the fit, the patient passes on the stage of coma. It may last for a brief period or, in others, deep coma persists till another convulsion. On occasion, the patient appears to be in a confused state following the fit and fails to remember the happenings. Rarely, the coma occurs without prior convulsion.
So she will convulse before she goes into coma. And like you have heard, occasionally she is confused. Or rather, initially, she's confused. She doesn't remember what has happened. And in severe cases, where the fetus is in situ, some doctors will not want to open her up at that time. How do you open up somebody in fits? So, but where the fetus is alive, it becomes a bit difficult. But where the fetus is not alive, destructive operation is done.
Management of eclampsia. Principles: arrest convulsion, maintenance of patient airway, breathing and circulation, oxygen administration at the rate of 8 to 10 liters per minute, terminate pregnancy, ventilatory support, prevention of complication, hemodynamical stable, prevention of life-threatening situation, postpartum care.
So these are the steps in management. You want to make sure you arrest the convulsion. And in that process, you must ensure that the airway is maintained. Otherwise, breathing will be stopped. You help the woman as much as possible. Like I said, where the baby is alive, measures are taken to open her up. But most times when it gets to this state, the fetus is not alive. So most doctors will prefer to do destructive operation, remove the fetus and the placenta and let the woman rest so that she can decide to start baby making earlier. Where any situation is life-threatening, it should be prevented.
First aid treatment. The patient, either at home or in the health centers, should be shifted urgently to the tertiary referral care hospitals because there is no place of continuing the treatment in such place. Sedation, maintain airway. Nursing management. Aim to prevent serious maternal injury from fall, to prevent aspiration, to maintain airway, and to ensure oxygenation. Patient is kept in railed cord and a tongue depressor is inserted between teeth. She is kept in the lateral position to avoid aspiration. Collect detailed history from the relatives, relevant diagnosis of eclampsia, duration of pregnancy, number of fits and nature of medication administered outside. Okay. So whenever you are free to come, you always will come here.
Do you know it was my own network and I was wondering? And Esina, can you see my
Screen? No, please.
you can't see?
Yes, sister, I can't see your screen.
Ah, just well. Can you see it now?
Yes, please, sister.
Ernestina, please continue.
Yes, sister. We have the nursing management. Aim to prevent serious maternal injury from fall to prevent aspiration.
Yes, please.
Okay. Okay, we have the nursing management. Aim to prevent serious maternal injury from fall, to prevent aspiration, to maintain airway, and to ensure oxygenation. 2. Patient is kept in railed cot and a tank depressor is inserted between the teeth. She is kept in the lateral position to avoid aspiration. Collect detailed history from the relatives, relevant diagnosis of eclampsia, duration of pregnancy, number of fits, and nature of medication administered outside. Continuous vital signs monitoring, hourly urine output monitoring, fetal heart rate monitoring, fluid balance, antibiotic therapy.
Why do we use hourly urine output monitoring? I'm asking the class, not Ernestina.
Sister, please, we want to check if the kidneys are well functioning.
Thank you. Continue.
Specific management, antihypertensive and sedative regime. 1. Magnesium sulfate therapy. IM, Pritchard regimen. Loading dose 4 gram IV, 3 to 5 minutes, followed by 10 milligram deep IM, 5 milligram in each buttocks. Maintenance dose 5 milligram IM, that is 4 hourly in alternate buttocks. IV Zospan or Sibai regimen. Loading dose 4 to 6 gram per 15 to 20 minutes. Maintenance dose 1 to 2 gram per hour IV. Lytic cocktail regimen. Diazepam. Phenytoin therapy. Antihypertensive and diuretics.
What do you people use? Do you use these same drugs for lytic cocktail? What do you use for lytic cocktail? Hello. Christy, can you please mute this Abby? Or you send her to the waiting room?
Has been muted.
Thank you. Is it that all of you have not nursed eclamptic patients before? This is obstetric management. The scheme of obstetric management of eclampsia. So you use anticonvulsants, antihypertensives, and diuretics. Now, when you use this, when the patient is not in labor, you try to control the fits. When the patient is in labor, you rupture the membranes and deliver, or you facilitate by using any form of induction or cesarean section. When fits are controlled, the pregnancy could go to term, it could be preterm, or you may lose the baby. So where it goes to term, in the end, that baby is born using any of these methods. Artificial rupture of membrane, then you deliver by induction. If it is a prematurity, of course, the doctor will be there, the obstetrician will prescribe what he wants, steroids and then delivery. And then if that baby is dead, again, you may induce to bring out or use anything to make sure that that baby is delivered. Where the fits are not controlled, where the fits are not controlled, you may begin to think of delivering the woman of that child, of the baby, and then you see what you can do between 6 to 8 hours. If the response is favorable, you induce, you deliver. And of course, when you see oxytocin, it means management of postpartum hemorrhage. You want to make sure the woman does not bleed. When the conditions are unfavorable, you open her up and bring out the baby. Now, where you do rupture of membranes, artificial rupture of membranes, you may want to use forceps, you may want to use ventus to cut short the second stage. You want to reduce the second stage, or still you do cesarean section. So in eclampsia, this is how the obstetrician will want to manage the condition. So the important thing there is assessing that condition to make sure that the condition is either favorable or unfavorable. And when you talk about favorable condition or unfavorable condition, your consent is first to the fetus, then to the mother. The next thing we want to talk about is anemia. Who else will help? Let Ernestina rest. Who will I call there? Who will I call? Who will I call? Ajara.
Yes,
Anemia.
ma.
Who is this? Idrisu. Okay.
Prof, please, I'm having a question concerning the eclamptic fit.
Okay.
At first, I was taught in my basic midwifery, you only start the max up when the woman starts fitting.
Okay.
But of late, I've been hearing people saying that you don't even wait for the woman to fit. That when you see the edema plus other sides, that you start giving. You don't wait for the woman to fit. So I want to clarify my thoughts.
I know that Maxov is given when you are managing eclampsia. And when we talk about management of eclampsia, for you to know that that woman is eclamptic, she has started fitting. She has started fitting. So I don't know, maybe there is another school of thoughts that says you start in severe preeclampsia. But how severe is the severe? I know that we give. For you to say the person is eclamptic, the person is fitting, or am I telling a different story?
No, Pro, that's what me too. I've learned previously, but now they are saying you don't wait for the woman to fit before you start giving the fit. So that's
I don't know.
macros.
I know
Okay.
MAPSOP
Thank
is
you.
used in management of eclampsia. In other words, the patient is fitting. Okay, Hajara, let's go ahead.
Okay, ma'am. Anemia in pregnancy.
Just a minute, let me get my cursor. Go ahead.
So, introduction. Commonest anemia in pregnancy. Introduction. Commonest medical disorder in pregnancy. 18 to 20 pregnant women are anemic in developed countries as compared to 40 to 75% in developing countries. It is responsible for significant high maternal and fetal mortality rates worldwide.
Anemia in pregnancy can never be overemphasized. That woman is pregnant, carrying another life, and she does not have enough blood to carry her. It becomes difficult. So we are told that in developed countries is about 18 to 20%, while in developing countries, 45 to 70%. And you won't be surprised because of the knowledge of adequate feeding. Okay. Hajara, you are asleep?
Definition. Anemia is a condition in which the number of red blood cells or their oxygen carrying capacity is insufficient to meet the physiological needs of the individual, which consequently will vary by age, sex, attitude, smoking, and pregnancy status. That is, according to 2013.
Yes. A condition in which the number of red blood cells or their oxygen carrying capacity is insufficient. Their physiological needs. That woman is carrying another life.
Anemia in pregnancy is defined as hemoglobin concentration less than 11 grams per deciliter.
Less than 11 grams per deciliter.
So when we come down, we have classifications of anemia. So under it, we have mild, moderate, severe, and very severe. So under the mild, the hemoglobin level is 9 to 10.9 grams per deciliter. In the moderate, we have 7.8 to 9 grams per deciliter. Severe, we have less than 7 grams per decimeter, and very severe, we have less than 4 grams per deciliter. Physiological, and so under the classification too, we have physiological anemia, and then the second one is pathological anemia. So under the pathological anemia, we have iron deficiency, folic acid deficiency, vitamin B12 deficiency, and then we have hemorrhagic anemia. So under the hemorrhagic, we have acute and chronic. So the acute, following bleeding in early months of pregnancy or antepartum hemorrhage. And under the chronic, we have hookworm infestation, bleeding pus, etc.
So all these ones are the hemorrhagic anemia. Bleeding in early pregnancy, that is bleeding in late pregnancy, and then bleeding due to other lesions. Then you have the hemolytic. Continue.
Hemolytic anemia, familial congenital jaundice, sickle cell anemia, etc. And then we have acquired. So under the acquired, we have malaria, severe infection, etc. And then we come to 5, which is bone marrow insufficiency. So under the bone marrow insufficiency, we have hypoplasia or aplasia due to radiation, drugs, or severe infection. So we come to number 6, which is hemoglobinopathies. So under the hemoglobinopathies, you have abnormal structure of one of the globin chains of the hemoglobin molecule of A. Please let me take it again. Hemoglobinopathies. So under the hemoglobinopathies, we have abnormal structure of one of the globin chains of the hemoglobin molecule, of globin chains of the hemoglobin molecule. Yeah, I think this is it's double.
There's a repetition there.
It's repetition.
Hmm.
So under it, you have sickle cell disease.
So it is actually globin chains of hemoglobin molecule. Of globin chains. You have the globin chains. Then you have to understand that the hemoglobin has these globin chains. When we talk about globin chains, we are talking about chains that are in the oxygen carrying capacity. You understand? So it is globin chains in the hemoglobin molecule of globin A. In the hemoglobin molecule, like you have the sickle cell disease or any of those varieties of sickle cell.
Physiological anemia of pregnancy. During pregnancy, maternal plasma volume gradually expands by 50%, an increase of approximately 1,200 ml by term. Most of the rise takes place before 32nd to 34th weeks gestation, and therefore there is relatively little change. The total increase in red blood cell is 25%, approximately 300 ml that occur later in pregnancy. The relative hemodilation produces a fall in hemoglobin concentration, thus presenting a picture of iron deficiency anemia. However, it has been found that these changes are a physiological alteration of pregnancy necessary for the development of fetus.
These changes are normal. They are required because like the hemodilution, you need enough to be able to carry the pregnancy. So there's that change. And when the change occurs and the blood cells are not enough, there is anemia. And that anemia is called physiological. It is not pathological.
Erythropoiesis. In adults, erythropoiesis is confirmed to the bone marrow. Red cells are formed through stages of A. Pronomoblast to nomoblast to reticulocytes.
Pronomoblast, which gives rise to what? To nomoblast.
Yes.
And the nomoblast gives rise to what? Reticulocytes, which eventually move forward to what? Nature nucleated erythrocytes. Continue.
The average lifespan of red cells is about 120 days, after which the red blood cells degenerate and the hemoglobin are broken into hemosiderin and bile pigments.
Broken into hemosiderin and bile pigments. Now, the normal lifespan of a red blood cells is, or the lifespan of a normal red blood cell, rather, is 120 days. What is the lifespan of a sickle red blood cell? Continue.
Iron requirements in pregnancy. During pregnancy, approximately 1,500 milligram iron is needed for increase in maternal hemoglobin, that is 400 to 500 milligram. The fetus and placenta into bracket 300 to 400 milligram. Replacement of daily loss through urine, stool, and skin is 2,500 milligram. Replacement of blood loss
250.
250 milligrams. Sorry. Replacement of blood loss at delivery is 200 milligram, and lactation is 1 milligram per day.
So if you calculate all that, you have about 1,500 milligrams.
Elemental iron, 30 milligram to 60 milligram. Folic acid, 400 microgram or 0.4 milligram. It is recommended for pregnant women to prevent maternal anemia, puerperal sepsis, low birth weight, and preterm birth of babies.
And when do you start education for this prevention? Hello.
This sister, it's from ANC.
Thank you.
Please, can I continue?
Continue. I've given you a new slide.
Okay. Iron deficiency anemia. About 95% of pregnant women with anemia have iron deficiency type. A pregnant woman is said to be anemic if her hemoglobin is less than 10 grams per deciliter. Causes: reduced intake or absorption of iron, excess demand such as multiple pregnancy, blood loss. Effects of anemia on the mother: reduce resistance to infection caused by impaired cell-mediated immunity, reduce ability to withstand postpartum hemorrhage, strain of even an uncomplicated labor may cause cardiac failure, predisposition of PIH and preterm labor due to associated malnutrition, reduced enjoyment of pregnancy and motherhood owing to fatigue, and then potential threat to life.
What do we mean by reduced enjoyment of pregnancy and motherhood owing to fatigue? Okay, continue.
Effects to fetus, that is the baby. Intrauterine hypoxia.
Hello, Zita.
Yes, please.
Please, with concerning that, we know that hemoglobin carries oxygen. So if the woman
Concerning what?
oxygen, please, the question that you asked, what is the meaning of the reduced oxygen?
Hey.
Reduce what? Are you asking a question or answering my question? Hello, Benis. She's been taken off.
Prof, I think she was trying to answer the question you asked earlier.
Oh, okay. Simple. Anemia causes fatigue, and that fatigue will militate against the woman enjoying her pregnancy or even her motherhood, because when she delivers, she will not be strong enough until she is well. Continue.
So, effect to fetus and baby. Intrauterine hypoxia and growth retardation. Prematurity. Low birth weight. Anemia a few months after birth due to poor stores. Increased risks of prenatal mortality and morbidity and mortality.
What does that bullet for? What is it talking about? Anemia a few months after birth due to poor stores. What does it mean? Midwives talk now.
Hello, Prof. Hello, Prof.
Yes, please.
Please, it means that maybe during pregnancy, she wasn't having enough iron. So right after delivery, the least blood that comes out after delivery comes out with most of the iron. So she
Sorry?
didn't have enough. Please, what is trying to imply is that maybe during pregnancy, she didn't have enough iron in the body. So after delivery, the least bleeding that comes with almost all the iron in her. So she didn't have enough to even reserve some for her during the postpartum period. Thank you.
So because of anemia, look at the face of that child. How old is that child? Looking like a 90-year-old man. But that's a newborn baby. Hello?
Hey.
Continue.
Prevention
Hi,
of
Prof.
iron deficiency anemia. The midwife can help to identify women at risk of anemia by accurate history of medical, obstetric, and social life.
True or false?
True.
Very true. And that's what you people do always. Somebody will say, what about social life? Somebody who smokes, somebody who drinks cannot eat well.
Management. Avoidance of frequent childbirth. Supplementary iron therapy. Dietary advice. Adequate treatment to eradicate illness likely to cause anemia. Early detection of fallen hemoglobin level.
Adequate treatment to eradicate illnesses likely to cause anemia. What are such illnesses?
Sister, please, malaria.
Malaria.
Malaria is number one. What else?
Fever. Sister, please,
Worm
hookworm
infestation.
infestation.
So you know them.
Yes, please.
Okay.
Curative management. Women having hemoglobin level of 7.5. Women having hemoglobin level of 7.5
5 milligram percent.
milligram percent, and those associated with obstetrical medical complications must be hospitalized. Following therapeutic measures are to be instituted. 1. We have diet, antibiotic therapy, blood transfusion, iron therapy, which may be oral or parenteral.
Which may be oral or parenteral.
Oral iron, daily dose 120 to 180 milligram is given. Management during labor. So during the first stage, special precautions: comfortable position on bed, light analgesia, oxygenation to increase maternal blood and prevent fetal hypoxia, strict aseptic techniques or strict asepsis.
Okay. So you have to take special precautions. And when you look to your right, contractions, push the baby down, push the fetus down. As the fetus gets down, the cervix is forced to dilate.
Second stage, usually no problem. IV metagen 0.2 milligram or 20 units oxytocin in 500 ml Ringer's lactate IV and 10 units of IM given. Intensive observation. Blood loss must be replaced by fresh packed cells and amount must
not exceed.
And the amount must not exceed loss amount to avoid overloading.
So before you give blood, even though she is anemic, you must measure the loss. So you give the amount that she has lost to maintain her.
Salpipirium. Bed rest. Signs of infection detected and treated. Pre-delivery iron therapy must be continued until patient restore. Diet. Patients and family members must be counseled for help at home regarding baby care and household chores.
Look at that baby. Is that baby looking healthy? Hello, midwives.
Yes, Prof.
Yes, Prof.
Ah, that's a pink baby looking very healthy, and it's taking you people 1 year to answer me. Go ahead.
Folic acid deficiency anemia. Into bracket, megaloblastic anemia. Folic acid deficiency anemia happens when body does not have enough folic acid. Folic acid is one of the B vitamins, and it helps your body make new cells, including new red blood cells. Deficiency of folic acid can cause placenta abruptio, neural tube defects, and congenital cardiac septal defects.
Yeah.
Vitamin B12 deficiency. Vitamin B12 deficiency, also known as cobalaminemia, refers to low blood level of vitamin B12. Deficiency of vitamin B12 can also produce megaloblastic anemia. Deficiency is most likely in vegetarians who eat no animal products.
Who does not eat animal products. Vitamin B12.
Sickle cell anemia. Sickle cell anemia is a disease in which body produces abnormally shaped red blood cells. The cells are shaped like a crescent or sickle. They don't last as long as normal round red blood cells. This leads to anemia. The sickle cell also gets stuck in blood vessel, blocking blood flow. This can cause pain and organ damage.
Before we get into the thalassemias, I asked you a question earlier. What is the lifespan of sickle cells?
90.
Sorry?
Prof, in 60 days.
Go into the net. Ajara, continue. Go into the net and give us the answer.
Thalassemia syndromes. The thalassemia syndromes are commonly found genetic disorder of the blood. The basic defect is reduced rate of hemoglobin chain synthesis. This leads to ineffective erythropoiesis and increased hemolysis with resultant in inadequate hemoglobin content. The syndromes are of two types, the alpha and beta thalassemia, depending on the globin chain synthesis affected.
And which one do we have commonly in Ghana? I am still waiting for lifespan of anemia, of the other one. Continue.
Conclusion. Anemia in pregnancy is the most commonly occurring disorder during pregnancy. So every mother who are pregnant must screen for anemia and must take treatment as soon as possible, along with food rich in iron, and also must have family support and care throughout pregnancy.
Apart from screening for anemia, what else must a pregnant woman do when you are talking of anemia? It's okay to screen, but what else should she do?
Putting prevention measures in place.
Sorry?
Putting preventive measures in place,
What
like
kind of
sleeping under
mosquito nets.
Sleeping
Undertreated mosquito net to prevent malaria.
Undertreated mosquito net.
And also taking prophylaxis
Mm.
during antenatal care.
So you know the preventive measures. What's the lifespan?
10 to 20
10
days.
to 20 days.
20 days.
So who told me 60 days? Midwives.
10 to 20 days.
So sister did what? You must not forget it. 10 to 20 days. Dennis, are you ready to read?
High premises gravidarum.
Don't make it a big noise, eh? Yeah, who is reading? Venice? Or who? Who is reading? Hello?
Hi.
Nobody is willing to read.
Sorry.
Teresa, you are
Sister,
making
can I
noise.
read? Please, you are ready.
Go ahead, please.
Introduction.
Okay.
Hyper means excessive. Emesis means vomit. Gravidarium, that's pregnancy. Nausea or vomiting of moderate intensity are especially common until about 16 weeks. ACG occurs when vomiting becomes intractable in early pregnancy and cause fluid and electrolyte imbalance and nutritional deficiency. Women usually need to be hospitalized. Definition. It is a severe type of
Christy,
vomiting.
can't you see this Erika disturbing the class?
Definition. It is a severe type of vomiting of pregnancy which has got deleterious effects on health of the patient and or incapacitates her day-to-day activities.
It incapacitates the woman's day-to-day activities.
Etiology. 1. Cause is idiopathic, but related to hormonal changes. When the level of ACG is high during pregnancy, severe vomiting occurs. 2. Other risk factors are overweight, multiple pregnancies, the presence of trophoblastic disease, which involves abnormal growth of cells in the uterus, and physiological factors.
And what?
Psychological factors, sorry. Is limited to first trimester and is more common in first pregnancy. Tendency to recur again in subsequent pregnancies. Is familial Familial history. Thus, mother and sisters also suffer from the same manifestation. More prevalent in hydatidiform mole and multiple pregnancy, and is common in unplanned pregnancies. Risk factors. 1. Age below 17 years and over 35 years. 2. Primi gravidi. 3. Multiple pregnancy. 4. Underweight and obesity. 5. Psychological factors such as unwanted pregnancy and marital problems. 6. Hyperemesis gravidarium. 7. Trophoblastic diseases.
The repetition of the hyperemesis gravidarum simply means that there are people that may not have any of these conditions, but they just have, for whatever reason, excessive vomiting in pregnancy.
Hyperemesis gravidarium.
We're still talking about the causes now.
The causes.
Hormonal. Are you okay? High HCG hydatidiform mole, multiple pregnancy, high estrogen. All these are hormonal. High progesterone, that is relaxation of cardiac sphincter because of the effect of the high level of progesterone in the blood. Other hormones involved are the thyroxine, the prolactin, the leptin, and then the adrenocortisol hormones. So what are we saying? Even though we know that the cause is idiopathic, hormonal effects could be a contributory factor. Then psychogenic, that's number 2. You have, they say it is probably aggravated. What am I saying? It's okay, it probably aggravates nausea. That is psychogenic. It probably aggravates nausea. Once it begins, it triggers neurogenic elements. So any of those causes that we have talked about would trigger nausea. And as soon as the nausea is aggravated, of course, the next thing you will have will be triggering of neurogenic element. Neurogenic element, they have to do with the nerves. That is the psychogenic. Then dietary deficiency. This could be due to low carbohydrate reserve, as it happens after a night without food, deficiency of vitamin B1, B6, and protein may be the effect rather than the cause. So when you talk about a woman that has hyperemesis gravidarum having deficiency in the B group of blood and then the protein, these ones are rather the effects, not the cause. The major cause is unknown. It could be hormonal or whatever. But again, when she doesn't eat She doesn't have enough carbohydrate in her system. It could trigger that. Allergy or immunological basis. Decreased gastric motility is also found to cause nausea. What do we mean by decreased gastric motility? Are there midwives in class? Am I muted?
No, sister.
No, sister.
Okay. So what do we mean by decreased
There are
gastric
midwives.
motility? When you talk about gastric motility, what are you referring to? Gastric movement, like the churning and all that. So when these movements are decreased, when gastric activities are decreased, it could cause nausea. Then you have the clinical course. We're talking about the course it takes. Early in pregnancy, vomiting throughout the day. Normal day-to-day activities are disturbed. They are interfered with. No evidence of dehydration, and there's no evidence of starvation. She's not dehydrated. She doesn't show signs of starvation, but she is vomiting. That is early. And then late, you have evidence of dehydration and starvation because she cannot retain any food, not even water. What are the symptoms? We're talking about excess vomiting, retching day and night. What do we mean to retch? What is retching? Hello, midwives, please talk. Ernestine, what do we mean to retch? Yes, Christy, class rep, retching.
Involuntary effort to vomit.
Involuntary effort to vomit. You feel like it, but it's not coming out. That's why for these people, the high parametric patients, they always have cracks on their throat, wounds, tear rather, because they will retch like that. Instead of vomitus, it will be mucus and blood. Gastric pain, constipation, tirelism, spitting, fatigue, anorexia. Complications will appear if not treated. Then the signs. You have signs of dehydration and ketosis or ketoacidosis. Then dry coated tongue, sunken eyes, acetone smell in breath. You have tachycardia. You have postural hypotension. Rise in temperature. Much later in pregnancy, there is jaundice. There is jaundice. Vaginal examination and USG done to confirm that what is happening to that woman is actually because of pregnancy. Investigations. You want to look at urinalysis. What is the quantity of urine that is passed? Is it okay? Is it small? Then the color. What is the specific gravity of that urine? Does the urine have acetone? Is there protein in the urine? Do we have bile pigments in that woman's urine? Do we have chloride in the urine? Is it enough? Is it adequate? Is it present or is it reduced? All these are investigations that are done. But again, as I will tell you, it may not have much to do with you. It may be in the laboratory. Then the biochemical and circulatory changes. You have serum electrolytes, you have sodium, potassium, and chloride. All these ones, they will want to find out, they will want to know. The doctor will want to know. Then you have ophthalmoscopic examination because of the excessive vomiting, because of the retching. There is bound to be effect in the eye. So this examination is required if patient is seriously ill. Is there retinal hemorrhage? Is there any sign of detachment of the retina? If there is retinal hemorrhage or detachment, there are very unfavorable signs. So they must be checked for. When there is abnormal serum potassium, that's where the serum potassium, doctor may want to do ECG for whatever reason. Now, you want to actually out. Is this woman really pregnant? And if she is pregnant, is it multiple? What could be the problem? Is it hydatidiform? So you have to go in for diagnosis. So the first thing you do is to rule out every other thing, confirm pregnancy. When you confirm pregnancy, you want to find out whether it is a singleton or a twin pregnancy. That is, you are now looking for associated causes that could cause vomiting like this. You are, of course, looking for using the sonographic tests, the uterosonographic test to test any of these things. That is the ultrasound to confirm whether it is a mole or really pregnancy. And if it is a pregnancy, how many are there? Then, of course, you have other complications like stress ulcer. Look at it there. I don't know whether you have ever noticed anyone. Stress ulcer in the stomach, esophageal tear, as I told you, I said the throat will be torn, it will crack. Jaundice due to liver damage. That retching causes jaundice later in the condition. Now, the only prevention is effective management to correct simple vomiting in pregnancy. That is the only way to prevent it. If the woman starts as much as possible, you look for what to give, you look for how to control, you manage. That is the only thing that can be done. Management, principles of management. Why do we undertake the management? Number one, to control vomiting. Number two, to correct fluid and electrolyte imbalance. One thing I want you to know is, ordinarily, somebody may not be pregnant, but that person is dehydrated. The person begins to vomit seriously. To correct metabolic disorders, and then to prevent serious complications of severe vomiting. Now, any patient that has hyperemesis gravidarum is hospitalized. So you admit the patient, open up an IV line. Why? You want to correct the fluid level. You now carry out the relevant investigations. You maintain an intake and output chart, monitor urine output, because you are sending in fluid. So to do this effectively, she's catheterized. Monitor the vital signs, test this urine periodically for ketone bodies. Oral feeding should be withheld for at least 24 hours. Because you do not want to trigger vomiting again. During this period, fluid given through IV drip method, through IV infusion. That's the only period. For that period, you have withheld oral intake. Therefore, the amount of fluid to be infused in 24 hours is calculated. How do we calculate it? Total amount of fluid should approximate to 3 liters, of which half is 5% dextrose and half is Ringer's lactate. Why do we have to give 5% dextrose? Please, I need an answer. You've been doing this. Why do we have to give 5%? Yes?
To sustain the woman because she doesn't eat.
Because she's not eating.
Yeah, so we give the 5% to sustain her from the hunger.
To prevent hypoglycemia.
Thank you very much. And then the Ringer's lactate?
To hydrate her.
To hydrate her. For hydration. Then extra amount of 5% dextrose equal to amount of vomitus and urine in 24 hours. So as you are given, that is how it is calculated. When you have given the 3 liters, you give extra 5% dextrose. And this 5% dextrose, you are measuring it vis-a-vis the vomitus and the urine output, because you want to make sure that everything is stabilized. urinary output in 24 hours. These measures will help to correct dehydration, to correct electrolyte imbalance, and to correct the acidosis, ketoacidosis. Then nutrition through nasogastric tube may also be given. It is not actually common to feed that patient through nasogastric tube. Over here, we don't do it commonly. What do we give to the patients instead of feeding per tube? What do we give? Hello?
Give them the IV fluid. IV fluid. The dextrose and then the Ringer's lactate.
Yeah, after that we do what? Most times our women begin to tolerate food, and so you give them dry biscuits and maybe lukewarm tea. Then the antibiotics, the antiemetics are given. Who can tell me a very good home remedy, antiemetic? Do you people have any?
Sister Ginger.
Ginger is good. Ginger is good. Star apple is good. But again, talking about hyperemesis gravidarum, are you sure she will be able to tolerate? So you give as prescribed by the doctor. And when you give, you support the nutrition with vitamins. Very important. So it depends on what the doctor prescribes, you give. The nursing care. So we are told that as a midwife, you should be sympathetic but firm with the patient. Daily monitoring of patient. You know why they're talking about being firm? Sympathetic but firm, particularly where it is psychological. Where it is psychological. Look for signs of improvement in the patient. Then you also look for signs of subsidence of the vomiting. You want to find out whether the patient has become, is feeling hungry. The patient is looking better. If the smell of acetone has disappeared from the breath and the urine. Check the pulse, check the blood pressure, and then the urine output. Monitor all the lab results because you want to be sure there's no more dehydration. Then monitor the fetal heart rate and fetal activity. And of course, the growth. Encourage patients to sit upright after meal. Encourage small and frequent meals. Liquids should be taken between meals to avoid distending the stomach. When the stomach is distended. But again, liquid taken between meals depend. Some people do not tolerate it. Some people want to finish eating their food before they can take any liquid. So you find out what is best for that patient because you don't want to trigger any more vomiting. Obstetric care. No therapeutic abortion is indicated if patient improves on therapy. Therapeutic abortion is seldom indicated on pregnancy associated with renal or neurological complications. We don't jump into wanting to terminate pregnancies anyhow. You only go about wanting to terminate a pregnancy when it is found that that woman will not be able to take that pregnancy to term. That is the only time you will want to terminate a woman's pregnancy. Before IV fluid is given, oral small and frequent dry meals without fat could be given. Dry carbohydrates like biscuits, toasted bread should be given. Remember, we have said that a major cause is reduced carbohydrate. So you have to want to maintain it, but then you want to make sure it is dry to avoid irritating hair. You give that. If she can tolerate ginger, like we have said, fine. It could help. Then gradually the patient will resume her full diet. I want to ask again, who has nursed a patient with hyperemesis gravidarum? What did you do? Can we gain that experience, please? Nobody? Midwives, you've never nursed a patient with hyperemesis gravidarum. January 6th. Okay, if you have questions, please ask. Where there's no question, can we call it a day? Our time is up. Hello.
Hi, Prof.
Hi.
Hi,
Asia.
oh, how do you have it?
Bye.
Bye, Prof. Have a
Bye.
nice
Someone
weekend.
just woke up. Aja.
Bye.